Welcome to the OncoPT Podcast, where you'll learn from oncology experts, practitioners, and patients to help you on your journey to become a confident and competent OncoPT. Here's your host, Elise Cantu.
Hey OncoPT, and welcome to this episode of the OncoPT Podcast. Now, we here at the OncoPT have surprisingly been doing episodes long enough that we need some update episodes from time to time, and today's topic is absolutely one that I am so ecstatic to be bringing back to the podcast. Now, way back in episodes 204 and 221, I know, literally 100 episodes ago, we had speaker Dr. Adam Matichak on the podcast to talk about BMTs and CAR T cell therapy, respectively. And since those episodes aired, there have actually been a lot of updates that are now more relevant than ever and more pertinent to cancer rehab and our involvement in these very special patient populations. So I have Dr. Adam Matichak back on the podcast today to talk about some of these updates and ultimately what this means for us, as you undoubtedly will see more of these patients in your own practice. So, Adam, welcome back to the OncoPT Podcast.
Good morning, Elise. Always fun to be back on the podcast with you. I think I'm going to set the record for most guest appearances on the podcast. I love it. So for those of you that haven't listened to our recordings on BMT and CAR T, please go back and listen to those first. I think it sets a good foundation for what we're going to talk about today. For those of you that are new to the podcast and have not heard me yet, my name is Adam Matichak. I am an inpatient hematology, oncology, bone marrow transplant, and immunotherapy PT at Stanford Healthcare in Palo Alto. I have been there almost a decade now, which is crazy to think about. And over the course of my 9 years there, we've seen a lot of advancements in bone marrow transplant, and then the addition of CAR T cell therapy, and then clinical trials and new therapies that we'll get into a little bit today. And then I want to touch on, like, one of the really neat things is the advancements that we've made in preventing and treating graft-versus-host disease for our allogeneic transplant patients. So let's get into it. That's
exciting stuff. Oh my gosh. So again, as Adam mentioned, I have linked the episodes. So episode 204 on BMT and episode 221 on CAR T in the show notes of your podcast player, and also on our show notes page for the OncoPT podcast. So I encourage you, if you have not already listened to those, go back and listen to those conversations before continuing with this, because what today is we are using those prior episodes as a springboard to then talk about what has changed, what has advanced since those episodes aired back in, oh my gosh, 2022, which is insane, like 3 years ago, y'all. So let's get into it real quick recap, just so we're all on the same page. BMT and CAR T cell therapy previously were kind of reserved for patients with hematological malignancies. And some of that's the same, some of that's different. And CAR T was this, I referred to it as like science fiction. It was like, it's the future of cancer treatment. And that has largely held up. And what's also exciting is that I think CAR T has paved the way for a lot of new, exciting, additional advancements and innovations within cancer treatment. And what I love about this, and this was kind of what we expected to happen, but I think we're there faster than what I thought we were going to be, is that BMT and CAR T are being used in more patient populations. So not just those very specific patient populations we talked about way back in episodes 204, 221, but now in greater presence within oncology. And that ultimately means for us as OncoPTs, we're going to be seeing these patients. So Adam, what have kind of been some of the updates, the innovations when it comes to BMT, CAR T since 2022, so 3 years ago?
Yeah, so starting with the BMT side, so not a whole lot has changed standard transplant-wise. We're still doing, as a country, about 10,000 transplants a year between allogeneic and autologous transplants. They're still primarily used for blood-based cancers, so our leukemias, our lymphomas, our multiple myelomas. One of the big advancements BMT-wise that we've seen recently is the addition of targeted CAR T cells on top of an allogeneic transplant. So basically what we're doing now is we're getting donor stem cells, and then we're also collecting donor T cells. So from the same donor, and those T cells are being sent off to be made into CARs. And then patient comes into the hospital, goes through their conditioning chemo, and then they get their transplant is basically split up over the course of anywhere between like 4 to 6 days, depending on, other risk factors that the patient has, protocols, things like that. So what they do is on day 0, they will get their T regulatory cells. On day +2, they'll get their T con cells. And then on like day +4-ish, they will get these donor allogeneic CAR T cells, which is really cool. So now we're seeing these T regulatory cells have had a chance to go into their bloodstream and search around and find all of these cancer cells. Mm-hmm. And then a couple of days later, we're getting this influx of CAR T cells that are targeted with a surface antigen for their specific cancer. And now you have these T regulatory cells that have already gone out and done the searching, and now they're telling these new CAR cells, like, this is where you're going and this is what you're doing.
Oh my God.
And so it's making our allogeneic transplants more effective because now they're way more targeted than they were before. Mm-hmm. Mm-hmm. So that's been really neat to see. Wow. So the downside of that is now we have these regular like allogeneic transplant patients that are now at risk for cytokine release syndrome and neurological changes because they're getting these CARs. So now we add in those CAR T side effects on top of, right, with our allogeneic transplants, we have the regular chemotherapy side effects from their conditioning. We still have that risk for acute and chronic graft-versus-host disease afterward. And then we add in this risk for CRS and ICANS. So it's kind of, roll the dice as far as what we're going to see and how they're going to present. But rehab-wise, not a whole lot changes. So for us on the inpatient side, when they're going through conditioning, my goal is education. These patients are still coming in, mostly independent, mostly doing well. So I am pushing them to take advantage of these first, few days in the hospital when they're feeling good, to stay active, to kind of get into a routine in the hospital, to make sure that they're out of bed for all their meals, that they're getting their walks in, that they're exercising, that they're, showering daily, those little things that are keeping them moving throughout the day, that they don't really think about at home, right? When we have our regular routine at home, and for a lot of these patients, it's hard kind of losing a lot of their autonomy when they're in the hospital. They're on scheduled vital checks. They have these like windows of when they can order their meals from the kitchen. So helping them kind of get into a routine and kind of bring some normalcy to their day is my biggest goal on the inpatient side.
Mm-hmm. Oh my gosh. I just have to pause here because one of the things that we talk about in OncoPT, and I feel like there's more of an understanding now than there was like 5 years ago. Initially, when we started treating cancer kind of more structured, in a structured format, in the late 1900s, I know, crazy to say, we did the best that we could as a healthcare community, as a medical community. We're doing the best we could. And unfortunately, a lot of people had very significant side effects. And some people did not live very long, maybe after they were diagnosed with cancer, after they went through cancer treatment. And now that we're into the 21st century, we have a lot greater expectations where patients are going to live longer after they've been diagnosed with cancer. We're better at treating people who have various diagnoses. We expect a longer life expectancy, and quality of life has really entered the conversation more. And that's, we could spend hours talking about that. And so all this to say, I bring this up because we have, at the time it was like, well, people are living longer, and now they're experiencing these side effects that we didn't expect. Like, we didn't know that they were going to experience, because frankly, people weren't living that long to get to the point where we say, oh, we're starting to see this. So fast forward today, 2025, we know this, we accept this, we expect this. And so now, again, kind of what you alluded to, Adam, is we know that our role in rehab is to spend a lot of time educating patients on what to expect and whatnot. And I feel like these advancements, these updates are the latest iteration of that, of we're getting better at treating these hematological malignancies with BMT and now the addition of CAR T cells. And that's awesome. That's great. Okay, now we have to expect potentially these other side effects. And then what can we do about them? So again, like, this is exciting because we're getting better at treating a person's cancer. Now it means that we have additional things that we need to be aware of and preparing our patients for in the short term and in the long term.
Yeah. And I think one of the other things that we've gotten better at is including rehab in this whole process, right? Like
Yes.
you think about, when Stanford started doing their bone marrow transplants back in the 1980s, and they didn't have a rehab team, right? Like these patients were thought to be like, they're too neutropenic. Their platelet counts are terrible. Like they can't do anything. Like they're susceptible for infection. They don't need strenuous exercise. It's not safe for them. Like think about how far we've come now to where, like, especially with our team, like we are a standard part of the order set for every patient that's admitted for transplant. They get an eval upon admission. We have an education packet that we've built out over the years that every patient gets. Like we are involved from the time that they step foot in the hospital until the time that they discharge. So I think, we think about the advancements in cancer care itself, but think about the advancements that we've made as a profession being involved in this whole continuum. And even outside of, BMT, from rehab's involvement in cancer prevention through survivorship and end of life, like there is so much more that we're doing now from the rehab side.
Oh my gosh. This is so cool to be like reminiscing in that way. Cause again, it's not perfect. We're still working on this, but we have come a long way in cancer rehab over the last decade plus, which is so exciting. So we've talked a little bit about the updates in BMT. Let's kind of shift to CAR T in that realm, because there's a lot more that seems like has changed and updated in this realm than what we talked about with BMT already.
And I think the biggest advancement in CAR T has been just the number of diseases that we're treating now. Right. If you think about when we first started, those first like Zuma 1 trials with Yescarta were strictly adult diffuse large B-cell lymphoma. Like that was it. That was the target. That's what we treated. It was CD19, CD22 targeted CARs, and that was it. Now we have CARs for almost everything. Like we have CARs for pediatric B-cell ALL. We have the Yescarta has been expanded to involve follicular lymphoma. We have CARs for multiple myeloma now. And then that has started to expand into the solid tumor world. So there's trials right now for CAR T for ovarian cancer, which we've seen a handful of. There's CARs for lung cancer, for breast cancer. And so we think about with CAR T cell therapy, right? We think about these modified T cells that have this single surface receptor that matches an antigen that's on the patient's specific tumor. And so that's where it gets tricky. I think we talked about this during our CAR T episode with like trying to make a CAR for solid tumors. Solid tumors, especially like in the abdomen, they share a lot of surface receptors with all of the other stuff that makes up our insides, right? So it gets a little bit tricky to find a good target for these things. So I think we're seeing a lot of like trial and error. We've had patients that have come in for a CAR for a solid tumor that have had like no response to treatment. Like it just did not work. So it does get a little bit tricky. But the other big offshoot of the CAR T cell therapy is now being able to treat autoimmune disorders. So we have a CAR T for lupus. We have a new CAR trial for for multiple sclerosis.
Ooh, that's exciting.
So like these patients with relapsing remitting MS, the goal of these CARs is to basically like down regulate their like B cell maturation to prevent them from having these wild flare-ups. So we can't cure MS yet, but what we're seeing is just this like steady, easygoing progression of their disease instead of these like massive spikes and then back to baseline. So it's been really neat. Yeah. And then, like you said, kind of the advancements in CAR T have opened the door to all of these other new cellular therapy lines that we're seeing. So the two big ones that we've had trials for are TIL therapy, which is tumor infiltrating lymphocyte therapy. So we are seeing patients with metastatic melanoma. And so what they do is they go into the site of their melanoma and they take out these lymphocytes that basically like they know how to find the tumor. Like they are tumor infiltrating lymphocytes. They know how to find it. They know how to get into it. They know how to destroy it. So we're taking these lymphocytes and we're taking them to a lab and we're letting them expand. And then we're taking this like massive quantity of TILs and then reinfusing them and letting them go do their thing. They know where to go, right? Like that's the big thing with targeted therapy. They know what they're looking for. They know how to bind to it and they know how to destroy it. And so the cool thing is we have not seen a lot of side effects from TIL therapy. The side effects come from what they do is, so similar to CAR T, they get a couple of days of chemo before their cell infusion, and then they get their cell infusion on day 0, and then starting 12 to 24 hours after their cell infusion, they start getting doses of IL-2. So it's an interleukin-2 cytokine that basically just helps keep that cell production up. But we're seeing a lot of side effects from the IL-2 infusions.
Interesting. Okay. What kind of, I haven't treated a lot of patients undergoing interleukin therapy. What kind of side effects are you seeing with that, Adam?
So a lot of like fluid retention type things. So we're seeing lymphedema, we're seeing pulmonary edema, we're seeing what's called capillary leak syndrome. So it's basically just like this like swelling in their like lymphatic system, in their muscles, in their blood vessels, like and then the other thing that we're seeing is renal disease. So from this like massive fluid retention, it's just putting a lot of stress on their kidneys. So think about things that are more like related to your body retaining fluid. Those are the kinds of side effects that we're seeing from IL-2.
Gotcha.
All right. And then the other big one is this new, like just FDA approved I think it was end of 2024 or right at the beginning of 2025.
This is like breaking news. Oh my God.
And so we have this new therapy called, and I don't want to screw it up. So this is TCR, and I always say TRC. TCR. This is T cell receptor therapy. So this is very similar to CAR T, where we're taking out a patient's T cells and we're letting them expand in a lab. The difference is we're not genetically modifying these T cells to have a surface receptor. These are natural T cells from the patient's own immune system. They kind of have these, already have these abilities to like go and find their cancer cells. So same thing, they're coming in, they're getting a couple of days of chemo, and then they're getting the cell infusion. So I think we were talking before we started recording about the differences between CAR T cell therapy and T cell receptor therapy. And so the biggest one is that the T cell receptors rely on a major histocompatibility complex from the tumor cell itself to be able to go and bind. The cool thing is that these MHCs are on the inside and the outside of the tumor cells. So it gives these TCRs more of an opportunity to bind. But like we were talking about earlier, cancer is really smart, unfortunately. And one of the ways that cancer tries to avoid, and this is how our normal immune system works, right? We have T cells that go out and find cancer cells and destroy them. And, in patients that, have these acute cancers, it's because the tumor cells are just proliferating too fast and our T cells can't keep up with them and they get overwhelmed. So with this T cell receptor, they rely on these MHCs to go find their tumors and destroy them. So cancer, being the smart thing that it is, it can downregulate MHCs that it presents as targets for these T cells. So again, a little bit tricky, but I think, we have some really smart people working on these things. So
yeah,
we'll get there.
It's, again, I remember saying, like I said, when I first learned about CAR T from my sister, who was at an institution where they were doing early work in that, I was like, oh my God, this is like science fiction. It's so crazy. And now, 5 years later, it's like, oh man, that is so old school. Like, look at what we're doing now kind of thing. So
Right.
It's just, it's new iterations of work that has been building for many, many years. And one of the things because I don't see a lot of patients who are undergoing this right now, but going back to CAR T, I believe it's Yescarta that we were talking about earlier. That's one of the CAR T lines. They are now using that as second line therapy and not just third line. So a lot of CAR T across the country, it's a third line treatment. So patients will have to go through and have 2 other lines of therapy fail them before they're considered candidates. And CAR T is even moving up in the ranks. So if you're listening to this right now and you're thinking, gosh, Adam is saying some cool things, this sounds awesome, I'm not going to see these patients though. I'm not going to see these patients in my practice. Friend, you are. And it's only a matter of time, because as we're hearing about new treatments that Adam is covering, as we're hearing about treatments we've talked about previously that are now moving up in the ranks of, kind of a priority. And when we're using them in cancer treatment, it's only a matter of time before you start encountering these patients, basically no matter the diagnosis that we're working with, which is really cool, but it might also be maybe a little intimidating for someone who hasn't had experience with this patient population yet, Adam. So what are some things, what does this all mean for rehab and the rehab professional who's like, okay, now I have to treat these patients? What the heck?
So there's 2 big things for the outpatient therapist. As CAR T becomes more prevalent, and it becomes safer because we have better ways of managing CRS and ICANS.
Yeah.
The patients that are going through it are going to continue to get more complex. So when we first started doing CAR Ts, I would say 60 to 70% of our patients were in between 20 and 35 years old.
Okay.
And now we have a pilot going on that we're getting going in our cancer center, where we're doing pre-assessments for our geriatric CAR Ts, because about 30% of our CAR Ts now are over the age of 65. So including, we just CAR T'd an 84-year-old 2 weeks ago.
Holy cow.
It's becoming more prevalent. So patients are going to get older, they're going to get more complex. The other thing that we're seeing now is using CAR T to potentially bridge a patient to an allo. So if we have a patient that is not responding to more traditional therapies to get them into remission, to get them to an allo, we might see them bridge with a CAR to get to their donor transplant.
Wow.
And so these patients are going to have these wider windows where they're outside of the hospital, but still have rehab needs. So I think we're going to see a lot more patients for prehab, I think, with this
yes. Oh my God.
this older, a little bit more beat up from multiple rounds of treatment. they're going to need a little bit of work before they come in.
Mm-hmm.
And the neat thing is, like, from the time that they apherese their T cells, like, it takes time to expand those cells, to make those receptors. So we have time from the time that they're consented, that they say, yes, I want to do this, to the time that they're ready to be admitted. Like, we still have a 3 to 4 week window where we can make a little bit of a difference in how they're moving, even if it's just like taking a really sedentary patient and getting them on a walking program to set that expectation for when you're in the hospital, we're going to keep you moving. We know we're not going to see like major gains in their fitness level from, 3 to 4 weeks, but it's enough time that we're kind of setting those habits so that
Absolutely.
when they're in the hospital, we're not starting at this really low baseline.
Absolutely.
And then, right, like we talked about, the other thing is on the back end, those outpatient therapists, like, you need to know what the like warning signs of like recurrent CRS and ICANS are. So looking at things like making sure that, it's probably not something that you think about doing a lot as an outpatient therapist, but checking vitals, right? Like, if your patient is hypoxic, if your patient is hypotensive, like, those are warning signs. If your patient, like, they're a little bit more fatigued, like, well, have you checked your temperature in the last 24 hours? Have you had a fever? Like, those are things that we want to look out for. And then we look at the ICANN side of things. Like, is your patient, a little bit confused? Are they more forgetful? Are, when they're going through their exercise program in your clinic, are they needing more cueing to do things? Like, those are little things that you start to pick up on, like, something's not quite right here. Like, maybe you should give your doc a call. Like,
right. As far as first of all, great reminder on vitals are vital for a reason, including outpatient oncology, even for patients who might be, on the other side of treatment. What about for someone who is maybe newer to a hospital system or a unit that's on the inpatient, the acute care side, that's now encountering these patients? What kind of things should they be? You provided great recommendations for the outpatient. Now let's flip it to inpatient side.
Yeah. So the biggest thing that we do on the inpatient side is keep people moving. So again, it's helping set those habits, set that routine, making sure that, like, especially for our CAR T patients that are, kind of on that like borderline, like CRS1, ICANS1, like those lower grade side effects, like making sure that they're doing the little things, that they're getting up into a chair for part of the day, that they're going for short walks, that, we're trying to maximize these windows that we have when they're feeling well. And then on the patients that are, maybe having the more significant side effects, kind of those like grade 2 into grade 3 CRS patients, it's really about patient safety, right? These patients are going to be hypotensive. They're going to be confused. They're going to be high fall risk patients. So, really want to make sure that, we're utilizing an extra set of hands when we need to, especially if the patient's more confused, a little aphasic. They're not following commands 100% of the time. So co-treating with your OT partners, using a rehab aide, pulling in a nurse, like making sure that we're doing everything we can to keep patients safe when we're trying to mobilize and keep them moving.
Yeah.
Our patients that are getting into that like grade 4 CRS and ICANS, like those are most likely going to end up in the ICU. So if you are a therapist that goes to the ICU, like making sure that therapy is staying on board with these patients, that, even if it's bed level, range of motion, anything we can do to maintain strength and function throughout their admission. And then we get them back on the unit after their ICU stay, or these patients that are like that grade 2 CRS, grade 2 ICANS that are staying on the unit with us, but maybe aren't really appropriate for therapy. When we pick those patients back up, they're going to get a lot of steroids as part of the treatment for their CRS and their ICANS. So making sure that, we're addressing things like steroid myopathy. So a lot of patient education, right? You might be a little bit weaker. You're going to fatigue quicker. So making sure that, again, we're keeping patients safe, that We know that they're going to be at risk for knee buckling. We know they're going to be at risk for dizziness, lightheadedness, things like that. So just adjusting your treatments as needed. One of the things that I always do with students and new grads is, when we're going in to see a patient that, is now like day +7 from their CAR, they just had like 2-3 days of like grade 2 CRS, so high fevers, maybe hypotensive, haven't been out of bed a whole lot. Like, what's your plan A? What's your plan B? And what's your plan C? Like, we need to have an aggressive plan for getting this patient moving. But if that doesn't go well, how are we pivoting during that session? Like, what are we falling back to?
Oh my gosh. Okay. I did not prep you for this question whatsoever, but you cued some thoughts. So I was speaking with a different physical therapist earlier this week who is in a system that they're like, okay, we recognize cancer rehab is important, but the bridge to like actually implementing it on a consistent basis is not there yet. But this physical therapist is in a position to like potentially build that up. I know for sure this institution is doing BMT. I don't know the status on like CAR T and other therapies, but I would think it's probably a matter of time. Just my hypothesizing. So what are some things that like a therapist who's in a similar position, what are maybe some things that from a planning standpoint, from an organizational administrative standpoint, what maybe can this PT do to set up that relationship to really build out this BMT rehab program? Like what are some considerations?
Yeah, I think there's a lot of research that shows that the more involved PT is, the higher patient's quality of life is, which I think should be at the top of the priority list, right? It's not always for doctors, but it should be pretty close to the top for us. And so really it's about finding a couple of attendings that are really pro mobility and planting the seeds with them. And then I think that's where it starts, is you find your docs that are on board with PT, with OT, and you get them to plant those seeds. And then you go from there. You just keep pushing, because it's hard. It's like organizationally, it can be really challenging, especially if, you have a system that's starting this new program, if they've never, I think that actually, take that back. That's probably a little bit easier. If they are starting a new program, that's when you can get your foot in the door early. And there's a lot of research that shows that, mobility through treatment is going to be effective for improving outcomes, for improving patients' quality of life. So I think that's where it's a little bit easier. If you are a new therapist in a healthcare system that already has this program and rehab has not been a big part of it, now you're trying to change the culture of the program, which is a little bit harder, right? So like I said, you find your couple of docs that are really pro mobility and you latch onto them and kind of just keep bugging people until you start to make a difference. I think, like I said, the research is out there that shows that, the more involved we are, the better patients do. So
be the squeaky wheel. I think Nicole Stout has said that, or again, somebody has said that. That's really stuck with me of you have to be the squeaky wheel in this situation. And one of the things that as more systems and institutions are looking to become centers of excellence or, have some kind of accreditation status, that requires some degree of rehab involvement. And so again, it's not that'll solve all the problems. But if you can leverage it to, if you can connect it back to that, I think organizationally people are more inclined to be like, oh, okay. So again, not a perfect fix, but if you can connect that, if that's a goal of this system or institution, that can definitely help get things a little, at least, more standardized, more implemented consistently for patients across the system. And I really like what you said about, champions, right? Finding those champions.
And then little things too, right? pushing your way onto multidisciplinary rounds or tumor board or those kinds of things where you're kind of, find your seat at the table or make your seat at the table. Like we gotta push our way into those multidisciplinary conversations because it's important.
Absolutely.
I think one of the things that we're trying to do right now is so we go to inpatient team rounds, our rehab team on our units, we go 3 times a week. And so we're very involved. Our docs know our team really well. So one of the ways that we're trying to now kind of push a little bit further upstream is being more involved in what our docs call new patient meeting. And so this is a meeting that they have once a week where they talk about like all of the patients that are, kind of on the board to be consented for transplant and any concerns that they have. And so this is where we're really trying to push for that like functional pre-assessment so that we can have a seat at that table. Like, hey, if we can, like, this patient's good to go, like they're active at home, they're moving, like no concerns. But if we get those patients that are a little bit higher risk, mobility wise, right? Do we now have the ability to sit at that table and say, hey, like this patient needs, a month of prehab before they come in for their transplant?
Absolutely.
Are we saying like, hey, if this patient, and it's hard with the transplant world because we have patients that from initial diagnosis, if they're genetically like, okay, like this, they're going to be super high risk. We're going to fast track them for BMT. Like that's a little bit tricky. But if we have those patients that are a little bit lower risk and we can say to that medical team, like, hey, if we can delay this for, a month or 6 weeks or 2 months safely, can we get them some rehab to get them stronger before they come in for their transplant because it's going to make things easier on the back end.
Again, what a great opportunity for rehab to show up. And, ultimately, this helps the medical outcomes for this patient. Again, well established, rehab is so beneficial here. And again, what a great opportunity for us to step into this as we continue to see these advancements. And there's going to be more. I'm going to have Adam on the podcast again in 3 years, and we're going to talk about, oh my gosh, can you believe that was the latest and greatest back then? Now talk about the new stuff we have here. This is only going to continue to happen. And it doesn't matter if we're talking inpatient, outpatient, acute care, and what diagnosis we're talking about. We're getting better at treating cancer in general. We're trying new things with different diagnoses. We're using the same things that we used to differently with different patient populations, like we've already talked about in this episode. The onus is on us to make sure that we are not only keeping up with these changes, but also thinking 2 steps ahead to make sure that as the medical side of treatment is advancing, we are also keeping up with that and making sure that patients are physiologically ready and able to undergo these very intensive treatments so that they can come out on the other side as best as they possibly can. And that excites me. Like, that's such a great place for us to be as we continue to propel cancer rehab forward, in my opinion.
Yeah. Like we talked about earlier, like being able to get our hands on these patients as early as possible, right? Like for our team, that was making sure that they were getting a PT eval as part of their order set. So as soon as they were admitted, that order was in. Like we didn't have to ask for it. We didn't have to wait for something to happen. And so now, right, it's continuing to push that envelope, right? So how do we get further upstream? How do we embed ourselves in cancer centers so that we're getting these patients, functional assessment prior to being screened for transplant or CAR T, to make sure that, like you said, functionally they are ready to go through something like that. That's what I tell every patient that comes in that I see is no 2 patients are going to go through this process the same way.
Totally.
And so making sure that, they're coming in as strong as they can, as functional as they can, it's going to give them a better chance to have a good outcome. So.
if you could go back in time, maybe not go back in time, but if you were speaking to you 9 years ago when you first started, and, wide-eyed Adam is like, oh my gosh, all these exciting things. What would you tell the physical therapist who's starting today with patients who are undergoing BMT, CAR T cell therapy, and those other treatments that we've talked about, TIL, TCR, etc.?
I would say the biggest thing is don't let either their treatment or their potential side effects of their treatment dictate what you do. So I think when I first started, especially because I started on our BMT unit as a student. So going from outpatient to like new acute care, and then on top of that, like cancer patients, like I've never worked with this patient population before.
Yeah.
Like these patients have got to be super sick and super frail, and the treatments that they're going through are really hard. And so I think, especially as a student, I probably underdosed my therapy for a lot of these patients. And so there's no reason not to be aggressive with rehab as long as the patient can tolerate it and you can do it in a safe manner. So making sure that, right, you're taking all of the precautions that you can, right? With our neutropenic patients, that you're, doing more therapy like in their room, not in a rehab gym where we're going to put them at risk for coming in contact with other patients. With our patients that are thrombocytopenic, making sure that, we're following precautions for resistive exercise and things like that. But there's no reason that we can't continue doing body weight exercise with them, that we can't get them on a stationary bike, that we can't make sure that they're walking every day. So it's like, I tell patients when they're coming through the transplant process, right? Like your honeymoon phase is from the day that you're admitted until like day plus 2 or 3 post-transplant, right? Like that is when you're going to feel your best. And then you're going to be like day plus 2 or 3 post-transplant. And that's when all of the chemo side effects, that's when being in the hospital for a week, that's when the post-transplant side, it's like everything's going to hit you all at once. But if we can just keep those patients moving through it, like, it's hard. And some days I have to be the bad guy where it's like, if I saw that patient on Thursday, right, and I don't see them again until Monday or Tuesday, it's like, well, what have you done the last few days? And if you haven't been out of bed a whole lot, I'm probably going to yell at you. But yeah, I think that's, if I went back and told myself what I know now, it's like, keep your foot on the pedal. Like, patients can tolerate a lot more than you think they can.
Yep. I think in general, like, we know how much we underdose patients, but I think especially in this patient population, it would be very tempting to slip into that. And we absolutely cannot. What resources would you recommend to someone who's newer to the BMT CAR T world to learn some more? We already talked about our 2 episodes, episode 204, episodes 221. But what else would you give or suggest to the person, the PT, who's like, I need to know more about this world?
Yeah, just email me and I'll walk you through the whole thing.
Love it.
No, I think one of my favorite resources for people is the BMT Infonet. A lot of great resources. I think the really neat thing about their platform is that they have it broken down like resources for healthcare providers. They have resources for patients and caregivers. And so what I recommend for people that are like new to transplant is go through some of that educational material for patients and caregivers first, because it gives you, kind of that like more simplified version of it.
Okay.
And then go back through the healthcare provider things, and it's going to fill in some of those knowledge gaps for you. But going through like the patient side of things first is going to give you kind of that real good simplified foundation of what the transplant process looks like.
Right.
Again, they have a lot of like patient testimonials and things like that. So you get to hear that patient voice out of it, which I think is great. BMT Infonet also has a survivorship symposium, which is a week long of content. It's free. You just have to sign up for it. You have to sign up for it ahead of time. That is the most important thing.
Okay.
I think all of the sessions are recorded and you have access to, I could be wrong. I think you have access to everything, but you have to sign up before the symposium. It's in May. I will be speaking at that as well. I'm actually really looking forward to that one. I'm doing a patient and caregiver kind of class on safe exercise and activity after graft-versus-host disease diagnosis. So we're going to go into all of that, like steroid myopathy. How do we keep people moving when they're fall risks? So that'll be good. The GVHD Alliance is another great resource for those more complicated patients. Does a really good job of breaking down GVHD by body system and the treatments that are available. NCCN has a great like educational pamphlet on the whole bone marrow transplant process, the CAR T process. So yeah, there's a lot of good resources out there. You can find a lot of them through the ASTCT website, which is the American like Cellular Therapy and Stem Cell.
Cool.
Yeah.
Cool.
I can never remember what their acronym actually stands for.
I'll find it. Don't worry. Yeah, I will be linking to all of those. Absolutely. Those are some really valuable resources you've mentioned. Keep going, Adam.
The ASTCT is kind of the big one.
Cool.
It's all of the stem cell and cellular therapy from across the country. The downside of that one is they have their conference the same week as CSM every year. So
ew, no. Dang it. Oh, okay. That's a big bummer. That's a really big bummer. I'll have to look into if they do any kind of like recordings or whatever to.
I think they do. I think they have an on-demand session like we do. Yeah.
I'll have to look into that. Oh man. Just not enough time for all these amazing conferences. Oh my gosh. With that said, Adam, now you are one of the things that I've so appreciated about you is that you're so willing always to, like you said earlier in the interview, of like talk people through this and have these conversations, because this is a very, Adam has done a really good job of simplifying and making this information very concise. I feel like you could get really lost in this information. And so I will be including all of those resources like we've talked about in the show notes as well. But if people did want to connect with you and continue this conversation, Adam, what's the best place for them to get in contact with you?
I'm on LinkedIn. I'm on the cancer rehab community on Circle. I am on Blue Sky. Honestly, at least you can put my work email in the show notes and people can email me and I will answer questions. Anything that comes across like the oncology listserv that's BMT and CAR T related, I'm always quick to answer those questions. So
amazing.
Lots of ways to reach out if you need anything.
All of that. And very responsive too. Like as many places as Adam is present, he's extremely quick to respond, which I so appreciate. Adam, thank you so much for this conversation today. It was, I went into this conversation very excited about the updates. And I feel like I came out more invigorated and like charged to go out and do more stuff about this because, like I mentioned previously, we've seen such crazy, wonderful updates over even just the last 3 years. What else are we going to see happen? And how much of a wonderful role that rehab has to play in all of this as more and more patients with different diagnoses get this amazing treatment and ultimately are going to have to, go through that and then come out on the other side. And eventually, we want them to get back to the things that they want to do and need to do with the people that they love as best as they possibly can. And we are perfectly primed to do that. So thank you so much, Adam. Is there anything else that you'd like to leave my audience with today?
If you have not already submitted your session and speaker application for the Cancer Rehab Community Conference, please do. If you are a loyal listener of this podcast, you know how much Elise and I push people. Like, your voice needs to be heard. There is something that you are an expert in that we need to hear about. So please get involved. Get involved on the cancer rehab community on Circle. Yeah, we need to hear from everyone that's involved in cancer rehab. Everyone has their little niche that they are, exceptional at, and everyone needs to hear from you.
That's excellent, because the deadline is also at the end of the week when your episode is releasing. So this is the best final pitch. Like, you've heard it from Adam. You've heard it from Kelly and me. We want to hear, and we need to hear your voice and perspective. Cancer rehab does not benefit from hearing the same people talking in echo chambers. We need you and your perspective, and I sincerely hope you will apply. I will also put that link in the show notes as well. So make sure that you do that. We cannot wait to read your application and see you at this year's Cancer Rehab Community Conference. Whoop, whoop. So Adam, thank you so much for that plug. You know I love a good conference plug. And with that, thank you so much again for coming on the episode. I'm so appreciative of your time and your expertise that you've shared. And until next time, this is Elise with the OncoPT. And remember, you are exactly the physical therapist that your patients with cancer need. So let's get to work.
Thank you so much for listening to this episode of the OncoPT Podcast. If you'd like to help support the podcast, please share it with others, leave a rating and review, or support us on Patreon.